Welcome to the Hospital Medicine Unplugged podcast.
It's good to be here. Today we're turning our attention to a topic that, on the surface, seems like a staple of daily hospital medicine and endocrinology, but has actually undergone a fairly radical transformation in just the last few years. We're talking about the thyroid carcinoma.
And specifically, we're looking at this through the lens of the peer-to-peer physician relationship. We know that for many of you listening, thyroid cancer might be taught as the good cancer or, the one with the simple algorithm.
Right.
But the reality in 2025 and beyond is substantially more nuanced.
Precisely. If you're consulting on a patient or managing a complex case, relying on the guidelines from 10 or even 5 years ago might lead you down the wrong path. We're seeing major updates in everything from the AJCC staging system to the 2025 ATA risk stratification guidelines.
I have to stop you there because when I looked at the prep notes for this deep dive, one graph literally made me spill my coffee. You look at the incidence of thyroid cancer over the last 30 years, and the line is going. It's just going vertical.
It is.
It looks like an infectious disease outbreak. If I just looked at that chart, I think we were in the middle of a global crisis.
It is terrifying on paper, isn't it? If you look at South Korea, for example, the rate of thyroid cancer diagnosis exploded by a factor of 15 in just 2 decades.
15 times. That's not a biological shift. Biology doesn't change that fast.
Exactly. And that is the aha moment. If this were a real increase in disease like, say, lung cancer from smoking, you'd see the mortality rate climb right alongside it.
People would be dying.
But in thyroid cancer, the mortality line is flat. It's a horizontal line at the bottom of the graph, completely ignoring the spike in diagnoses.
So we aren't finding more cancer that kills people. We're finding more cancer that doesn't matter.
That is the controversial, uncomfortable truth we have to start with. We're finding reservoir disease. We're catching tiny millimetric papillary cancers that were quite happily sitting there doing absolutely nothing, and likely would have continued doing nothing until the patient died of old age.
This sounds like the central paradox we need to unpack today. It really sets the stage for everything else we discuss, from the molecular pathogenesis to the de-escalation of radioiodine.
It does.
So our roadmap for this deep dive is clear. We'll start with the epidemiology and the reality of overdiagnosis. Then we'll move into the nuts and bolts of the AJCC 8th edition staging and why that age cutoff shift matters so much.
That age cutoff is a critical piece of the puzzle. From there, we'll explore the 2025 ATA risk stratification, specifically the shift from a static to a dynamic risk assessment, which is a game changer for long-term follow-up.
And we have to get into the genetics.
Oh, absolutely. We'll get into the genomic duet, the molecular markers that are redefining prognosis, and finally, we'll cover the new horizons in systemic therapy for refractory disease.
It's a full slate. Let's begin with the numbers. The epidemiology here is, well, it's striking. Thyroid carcinoma is now the 9th most common cancer globally.
Right. And it's unequivocally the #1 endocrine malignancy.
To give you a sense of the scale, we're looking at approximately 821,000 new cases per year worldwide. That's a huge number.
It's a staggering number.
Yeah.
And the demographic distribution is quite specific. There's a striking female predominance. About 75% of cases occur in women, which gives us a ratio of roughly 3-to-1 compared to men.
And we still don't fully understand that, do we? There are theories.
There are. It has led to a lot of speculation about hormonal drivers, estrogen receptors on thyroid cells, and various reproductive factors. But the disparity remains one of the most consistent features of the disease.
Okay, so in terms of age, the median diagnosis lands in the early 50s. However, and this is a crucial point for our colleagues in internal medicine and pediatrics, it's the most common malignancy in adolescents and young adults.
Yes, specifically that 16 to 33-year-old cohort.
That's a demographic where a cancer diagnosis carries a unique weight. When you diagnose a 22-year-old, you're talking about a disease burden, or at least a surveillance burden that could span 60 years.
Exactly. But what's most alarming to public health experts is that trend line we touched on earlier. Over the past 40 years, the global incidence has increased dramatically.
The data shows the age-standardized incidence rate rose from 2.11 per 100,000 in 1990 to 3.15 per 100,000 in 2017. And you mentioned there are regional hotspots that are posting numbers far, far above that average.
South Korea is the prime example here. They have the highest rates globally, with 45 cases per 100,000 women. We also see very high rates in Cyprus, Ecuador, China, and Turkey.
I want to dig into the South Korea example because it serves as such a powerful cautionary tale for the rest of the world. Why is it so high there? Is there an environmental factor? Is it dietary iodine? What's the driver?
It's almost entirely iatrogenic.
Iatrogenic.
Yes, but not in the way you might think. It wasn't caused by a drug or a toxin. It was caused by a screening program.
Right.
In 1999, South Korea initiated a national cancer screening program. For a very small fee, or often for free, citizens could get an ultrasound of the neck along with their other health checks.
So you hand a high-resolution ultrasound probe to thousands of clinicians and tell them to look at the thyroids of the entire population.
Exactly. And the thyroid is a lumpy organ. It's not smooth. If you look closely enough with high-frequency ultrasound, you will find nodules in a huge percentage of the adult population.
What kind of percentage are we talking?
Some studies say up to 50 or 60%. And within those nodules, you'll find tiny foci of papillary thyroid cancer.
So incidence goes vertical. And yet, as we noted at the top, mortality stays completely flat.
Completely flat. Mortality rates have remained stable at approximately 0.5 per 100,000. So you have incidence going vertical and mortality staying flatline. This widening gap strongly suggests that overdiagnosis is the major driver of this so-called epidemic.
And when we say overdiagnosis in this context, we are referring to the detection of small, low-risk papillary thyroid cancers that, in all likelihood, would have remained indolent and never caused the patient clinical harm.
That's the definition. This is largely driven by the increased use of thyroid ultrasonography and the detection of incidental findings, those incidentalomas picked up on CTs or MRIs, done for other reasons.
So someone gets a neck CT for trauma, and there it is.
There it is. The data suggests that up to 75.6% of thyroid cancer cases globally may represent overdiagnosis.
And in those high-income nations we mentioned, like South Korea, you said that rate exceeds 85%. That's astounding. It creates such a significant dilemma for the clinician. You find a nodule, you biopsy it, it's cancer. But was it a cancer that needed finding?
That is the core ethical and clinical question we're all grappling with now. Thankfully, we are seeing a shift. Countries like the US, Canada, France, and even South Korea have seen a plateau or even a decline in incidence since the early 2010s.
Why the change?
It reflects revised clinical practice guidelines that are explicitly aiming to curb unnecessary detection. We are learning to look away from the millimetric, insignificant findings. We're getting better at telling patients, yes, there's a tiny spot there, but the best thing to do is nothing.
That brings us perfectly to how we categorize these patients once they are diagnosed. The staging systems have had to evolve to reflect this new reality that not all thyroid cancers act the same.
They absolutely have.
This is one of those things that always confused me about thyroid cancer. In almost every other solid tumor lung, colon, breast stage is about anatomy. How big is it? Where did it go? But in thyroid cancer, age is part of the staging.
It's a huge factor.
And now, the AJCC 8th edition staging system introduced a major change that every physician needs to be aware of.
The critical update in the 8th edition is the age cutoff. In the previous 7th edition, the cutoff for risk stratification was 45 years. The 8th edition moved that line to 55 years.
Okay, so this wasn't an arbitrary administrative change. It was based on robust data regarding prognosis. But walk me through the logic. Why 55? Is there some magical biological switch that flips when you blow out the candles on your 55th birthday?
It's not a light switch, no. It's a continuum. But the data, specifically from a massive international data set of over 9,000 patients, showed that the mortality risk curve starts to bend upward significantly around that age.
So it's just where the data inflection point is.
Exactly. Younger bodies handle this disease differently. Their tumors tend to differentiate better. They respond to radioiodine better. It's a fundamentally different disease in a younger person.
So a 25-year-old with a lung metastasis, in the old way of thinking, that sounds like a death sentence. That sounds like stage 5.
In lung cancer, it would be, absolutely. But in thyroid cancer, that 25-year-old with a lung met is still stage 2. And here's the kicker. Their 10-year survival is still near 100%.
That's mind-blowing. You can have cancer in your lungs and still have a near-perfect survival rate.
If you're young. That is why the cutoff shift matters so much. We're overstaging these middle-aged patients, people between 45 and 55, telling them they had advanced stage disease, when their survival curves actually look just like the younger cohort.
So you were giving them a terrifying prognosis that wasn't accurate.
Precisely. By shifting the cutoff to 55, the staging system now better aligns with the actual survival data. It's a much more accurate tool.
Let's break down what staging looks like for those patients under 55 years old. It's remarkably simplified now.
It is. It's very simple. If a patient is under 55, they are essentially stage I or stage 2. That's it.
Okay, so what's stage I?
Stage I is defined as any T, any N, and M0. That means they can have a large primary tumor, they can have positive lymph nodes, but as long as there are no distant metastases, they are stage 1.
And stage 2 for this age group is reserved strictly for those with distant metastases.
Correct. NET, NEN, M1. The prognosis really supports this simplicity. In this age group, we see greater than 98% survival after a median follow-up of 6.8 years, regardless of the treatment intensity. It emphasizes that for young patients, this is an incredibly survivable disease.
Okay. Now, for patients 55 years and older, the staging becomes more granular.
Right. So the older cohort, we revert to the more traditional stage through IVB stratification, which is based on tumor size, nodal status, and extension.
So for them, T and N status matter for stage.
Yes. For example, stage I is a small tumor, T1 or T2, with no nodes. Stage 2 introduces nodal involvement or larger tumors. But there's another specific definition change in the 8th edition that's worth highlighting regarding T3b tumors.
This is the reclassification of extrathyroidal extension, right?
Exactly. Previously, even microscopic extension of the tumor outside the thyroid capsule could bump a patient up in stage. The 8th edition now requires gross invasion of the strap muscles for a T3b classification.
That is a significant distinction. Microscopic extension was often just a pathological finding that didn't necessarily correlate with the clinical behavior of the tumor.
Not at all. It was an observation under a microscope. By requiring gross invasion, something you can see with the naked eye at surgery or on imaging, we're being much more specific about what constitutes truly aggressive local behavior.
And what's been the impact of that change?
The impact has been that many patients who would have been considered higher stage are now downstaged. This leads to improved prognostic accuracy. We aren't overcalling the risk for someone just because of a few cells crossing the capsule.
So we're getting better at matching the stage to the actual risk?
Much better.
Looking ahead, is this the final word on staging? Or is it still evolving?
It's always evolving. There's emerging research suggesting that even this 55-year cutoff might be refined further. Some data suggests we might eventually have histology-specific cutoffs.
Meaning what, exactly?
Well, maybe 50 years for papillary thyroid cancer and 40 years for follicular thyroid cancer.
Yeah.
The biology is a bit different, and we cannot ignore the role of molecular markers.
Right, the genetics.
We'll discuss the biology in depth shortly, but markers like BRAF, that's BRAF, and TERT promoter mutations are poised to modify stage in future iterations. We are moving toward a system where biology trumps anatomy.
So AJCC staging helps us predict disease-specific survival, who lives and who dies. But in thyroid cancer, where mortality is so low, the day-to-day clinical question is usually about recurrence. Will the cancer come back?
That is the more common question, yes. And that's where the ATA, the American Thyroid Association risk stratification, comes in. The 2025 guidelines provide a superior framework for predicting structural persistence or recurrence compared to the AJCC system.
Okay, so let's be clear on the distinction. AJCC predicts death. ATA predicts recurrence.
That's a great way to summarize it.
The 2025 system categorizes patients into 3 main buckets: low risk, intermediate risk, and high risk. Let's define the low-risk patient. Who is that?
Low-risk patients have intrathyroidal disease. If there are lymph node metastases, they are micrometastases, specifically 5 or fewer foci that are millimetric in size.
Tiny amounts of cancer in the nodes.
Exactly. The recurrence rate in this group is approximately 1.5%. These are the patients where we really want to minimize aggressive therapy.
Okay, then we have the intermediate risk bucket.
This group is a bit broader. It's actually split into low intermediate and high intermediate, but overall they have a recurrence rate of about 5.4%. This might include slightly larger tumors or more nodal involvement.
And finally, the high risk group.
These are the patients with gross extrathyroidal extension, significant nodal disease, or distant metastases. Their recurrence rate jumps to around 25%.
But the real innovation in the 2025 guidelines isn't just these static buckets at the time of diagnosis, it's the concept of dynamic risk stratification.
Yes.
I want to circle dynamic risk stratification in red ink, because for the hospitalists listening, this changes how we talk to patients. The old way was, you have a high-risk tumor, you are high risk forever.
Right. It was a label tattooed on their forehead for life.
But the 2025 guidelines say that label is written in pencil.
That's a beautiful way to put it. Let's take a concrete example. You have a patient, maybe 50 years old, pretty bulky tumor, maybe some lymph nodes. The surgeon takes it out. The pathologist says, this looks aggressive. So on day 1, that patient is intermediate or even high risk.
And the patient is terrified.
Naturally. But we treat them. Maybe they get surgery, maybe some radioiodine. 6 months later, we check their labs. Their thyroglobulin is undetectable. Their neck ultrasound is completely clean.
So anatomically and chemically, they look clear.
Exactly.
Mm.
Under the dynamic system, that patient has now moved into the excellent response category. Their risk of recurrence has dropped from maybe 20% down to less than 5%, often significantly lower than that.
So we've essentially restaged them based on their response to therapy.
We've restratified them. And this allows us to tell the patient, I know the pathology report said last year, but look at how your body responded. You are now low risk. It permits us to de-escalate surveillance.
It stops the scanxiety.
It stops the scanxiety. It stops ordering CT scans every 6 months. It's a fundamental shift in long-term management.
The guidelines outline 4 response categories. Let's walk through them because this is the terminology we should be using in our progress notes and our handoffs.
Okay. The best place to be is excellent response, as we just described. This is defined by a low thyroglobulin and no structural evidence of disease on imaging. The risk of recurrence is less than 5%.
Then there is the indeterminate response.
This is a gray zone. It usually involves mild elevations in thyroglobulin or nonspecific findings on imaging, perhaps some faint foci on an ultrasound that are too small to biopsy. The recurrence risk here is about 17%.
So it's a signal to watch closely, but not necessarily to intervene immediately.
Exactly. Watchful waiting.
Next is biochemically incomplete.
This means the thyroglobulin, our tumor marker, is elevated or rising, but we cannot see a tumor on any of our imaging. The risk of future structural recurrence here is about 58%.
And finally, structurally incomplete.
This is the highest risk group. It means there is visible, identifiable disease on imaging. The recurrence or persistence risk here is roughly 84%.
The beauty of this dynamic system is that it offers hope. The data shows that most patients, even those with initial risk factors, can achieve an excellent response over time.
That's right. In large cohorts, up to 83.2% of patients achieve an excellent biochemical response at their final assessment. It allows us to reassure patients. Yes, you had a scary feature on your pathology report, but your response to treatment has been perfect, so your risk is now very low.
To understand why some patients respond so well and others don't, we have to look under the hood at the molecular pathogenesis. Let's get into the weeds of the biology, because this feels like the area that has changed the most since I was in residency.
It definitely has.
We used to just call it papillary and move on. Now we're talking about BRAF, RAS, TERT. Help me organize this landscape.
Okay, think of the thyroid cell like a house. The main door that tells the house to grow and divide is the MPK pathway. In thyroid cancer, that door gets jammed open.
Okay, jammed open, so the signal is always on.
Right, always on. And the most common way that door gets jammed is the BRAF V600E mutation. That's the heavy hitter. It's found in about 60% of papillary cancers.
And BRAF is the bad actor here, from a prognostic standpoint?
It's the more aggressive actor, for sure. But here's the mechanism you really need to understand for therapy. When BRAF is overactive, the cell stops acting like a proper thyroid cell. Specifically, it stops making the sodium iodine symporter, the NIS.
The pump that sucks up the iodine from the blood.
Exactly. If the cell de-differentiates, if it forgets how to be a thyroid cell, it stops sucking up iodine. Which means if you give that patient radioactive iodine, the tumor just looks at it and says, no thanks. It won't absorb the poison.
Which explains why BRAF-positive tumors are so often refractory to our best treatment.
Precisely. That's the key connection. On the other hand, we have RAS mutations, NRAS, HAS, CRAS.
And these behave differently, I take it.
Very differently. RAS mutations are typically found in follicular patterns, so follicular variant papillary carcinoma and classic follicular carcinoma. And they have a propensity for vascular invasion rather than nodal spread. They like to get into blood vessels.
But there is a silver lining with RAS mutations when it comes to treatment.
There is. They often retain radioiodine avidity. They respond better to RAI therapy than their BRAF counterparts because the MPK pathway output is a bit lower. The cell is still acting enough like a thyroid cell to take up the iodine.
Okay, so we have BRAF and RAS. What else is in the mix?
We also see RETPTC rearrangements. These are chromosomal fusions, and they're particularly common in children, up to 60 or 70% of pediatric cases. And they're also strongly associated with radiation-induced cancers, like from Chernobyl.
And the good news there.
The good news is that these are highly targetable with selective RET inhibitors, which we'll discuss when we get to systemic therapy.
Now, what about this genomic duet I keep reading about? That sounds poetic, but I assume it's not good news.
It's a funeral march, unfortunately. This refers to the co-occurrence of TERT promoter mutations with that BRAF V600E mutation we talked about.
Okay, so TERT and BRAF together.
Right. TERT mutations occur in about 4.6% of cases. On their own, they're concerning. They're associated with more aggressive disease. But when they happen alongside BRAF, the prognosis worsens dramatically.
So it's not just additive risk. It acts as a multiplier.
It is absolutely synergistic. Individually, they're bad. Together, they are a completely different animal. They essentially rewrite the cell's immortality program. If you see TERT and BRAF together on a molecular panel, you are dealing with a high-risk neoplasm. That is not the good cancer anymore.
So that finding should change your management.
It should. It confers high-risk features and poor clinical outcomes, often justifying a potential stage upgrade in our mental model of the patient, even if it's not yet formally in the staging system.
Understanding these molecular drivers directly informs our therapeutic choices, particularly regarding radioactive iodine, or RAI. We're currently in an era of de-escalation, which seems to be the theme of this whole discussion.
It is. We have moved away from the ablate everyone philosophy. We used to give RAI to almost everyone to wipe out any remnant thyroid tissue. Now the decision is highly individualized.
So we have clearer criteria now for who should not get RAI. Let's walk through that.
Correct. The guidelines are quite specific. You typically do not recommend RAI for patients with classic papillary thyroid carcinoma that is less than or equal to 2 centimeters, is intrathyroidal, and is unifocal.
What about multifocal disease?
You can still withhold RAI in multifocal disease as long as all the foci are small, usually under 1 centimeter.
Okay, what else?
And we need to confirm they're clinically node negative and have a negative post-op ultrasound. And crucially, a postoperative unstimulated thyroglobulin, or TG, of less than 1 nanogram per milliliter. If a patient meets all those criteria, the benefit of RAI is negligible, and you're just giving them unnecessary radiation.
What about the evidence supporting this? It can be hard for a physician to do less when the word cancer is involved. Patients expect action.
We have excellent data from the Estimable 2 trial. This is a prospective randomized trial that looked at exactly this question in low-risk patients. It demonstrated non-inferiority of a no RAI strategy.
What were the numbers?
The recurrence rates were 4.1% with RAI versus 4.4% without RAI. That difference is statistically insignificant. It's clinical equipoise.
So for low-risk patients, we can confidently spare them the radiation exposure and the isolation that comes with it.
Confidently.
But there are patients who fall in the middle, the selective recommendation group.
This is where clinical judgment comes in. This is the art of medicine. We might consider RAI for larger tumors, say greater than 4 centimeters, or if there are microscopic positive margins on pathology.
Or if there are certain high-risk histologies.
Exactly. If the path report comes back with tall cell, columnar cell, or hobnail variants, that might tip the scales toward giving RAI. The same goes for if there are a small number of millimetric central lymph nodes involved. It's a risk-benefit calculation you have with the patient.
Then there's the group who definitely should get RAI.
These are the clear-cut cases. Gross extrathyroidal extension into the strap muscles, bulky nodal disease, meaning more than 5 positive nodes, or any distant metastases.
Here, the evidence for benefit is well established, right?
Absolutely. In these high-risk patients, RAI has been shown to improve overall survival and decrease recurrence. The hazard ratio for survival improvement is 1.43, and for decreased recurrence, it's 1.32. So in this population, we hit hard.
And again, the genetics we just discussed inform the likelihood of success with RAI.
That's right. As we noted, RAS mutations and RAT fusions tend to have a favorable response. They'll likely suck up the iodine. But if you see BRAF, TERT, or TP53 mutations, you should anticipate potential resistance.
So when a patient is resistant, when they have radioiodine refractory differentiated thyroid cancer, we enter the realm of systemic therapy.
And this is reserved for disease that is progressive or symptomatic. That is a key distinction. We don't treat just because a number on the lab sheet changed or a spot on the scan grew by millimeter. These drugs have real toxicity.
We have these shiny new toys, lenvatinib, cabozantinib, the specific RT inhibitors. The response rates can be amazing. Lenvatinib has a response rate over 60%. But these are not sugar pills.
Far from it. And this is often the hardest conversation in oncology. You have a patient with metastatic disease. You can see it on the scan. It's there. The instinct for both the patient and the physician is to attack it.
The don't just stand there, do something impulse.
Exactly.
Yeah.
But lenvatinib causes significant hypertension, diarrhea, profound fatigue, hand-foot syndrome where your skin literally peels off.
Yeah.
If the patient is asymptomatic, if they're walking around playing golf and feeling fine, Do you want to give them a drug that makes them feel terrible just to shrink a spot on a scan that isn't bothering them?
This is the concept of structural progression versus symptomatic progression.
Precisely. If the tumor is growing 1 millimeter a year and not near any critical structures, you wait. You sit on your hands. Because once you start these multi-kinase inhibitors, the clock starts ticking on resistance, and the quality of life invariably takes a hit.
You save the big guns for when the wolf is actually at the door.
Not just when you hear him howling in the distance. That's a perfect analogy.
Okay, but when the time comes, what are the options? The first-line therapy of choice these days involves multi-kinase inhibitors.
Lenvatinib is the preferred agent here. The efficacy data is very impressive. In the pivotal clinical trials, it showed a median progression-free survival PFS of 18.3 months compared to just 3.6 months for placebo.
That is a massive difference. That's more than a year of control.
It is. It was a practice-changing trial. The response rate was 64.8%.
We also have sorafenib in the toolkit.
Sorafenib is an alternative, yes, but the numbers aren't quite as robust. The response rate is lower, around 12.2%, and the PFS benefit is smaller. So lenvatinib is generally the heavy lifter in the first line for most patients.
If the patient progresses on lenvatinib or sorafenib, what's the second-line option?
Typically, we move to cabozantinib. In a trial of patients who had progressed on prior therapies, it demonstrated a median PFS of 11.0 months. So it's another effective agent.
But the whole field is moving toward precision therapy. If we have those molecular targets we identified earlier, we should be using drugs designed specifically for them.
Absolutely. If a patient is RET fusion positive, we look to selective RET inhibitors like selpercatinib or pralsetinib. This is true precision medicine.
And the response rates for these are staggering, aren't they?
They are. Greater than 79% for selpercatinib and 89% for pralsetinib in some cohorts. And the durability of response is excellent, with many patients staying on therapy for years.
For those BRAF V600E mutations, specifically in RAI refractory disease or the even more aggressive anaplastic thyroid cancer, we have options too.
We do. The combination of dabrafenib plus trametinib, a BRAF and ME inhibitor combo. In anaplastic thyroid cancer, which is notoriously aggressive, this combination showed a response rate of 56% and a median overall survival of 14.5 months.
That's a huge improvement.
It's a monumental improvement in a disease that historically had a survival measured in weeks.
We should also briefly mention medullary thyroid cancer, which is a different beast entirely.
Yes, it's important to separate it. Medullary cancer arises from the parafollicular C cells, not the follicular cells that cause papillar and follicular cancers.
Right.
For these patients, if they have an AKRET mutation, selpercatinib is the preferred treatment.
Before we wrap up the therapeutics, we just need to reiterate that caution on starting these systemic therapies.
Yes. These are not curative drugs. They are cytostatic or palliative. They come with significant side effects that require active management: hypertension, diarrhea, fatigue, hand-foot syndrome.
So watch and wait is a valid and often preferred strategy for indolent disease.
It absolutely is. If the patient is asymptomatic and the disease is growing very slowly, it is often better to preserve their quality of life than to rush into a tyrosine kinase inhibitor.
This brings us to the synthesis of everything we've discussed today. We've traveled from the epidemiology of overdiagnosis all the way to the cutting edge of precision oncology.
The overarching theme is really a tale of two diseases. It's less is more for the low-risk majority versus precision intensity for the high-risk minority.
So we're doing less surgery and less RAI for the small, indolent cancers.
But we're using sophisticated genomic profiling and targeted therapies for the aggressive ones that are actually a threat to the patient's life.
It's a shift from a one-size-fits-all approach to truly personalized medicine.
It connects back to everything we talked about, that AJCC age cutoff, the dynamic risk stratification. We are getting better at identifying who actually needs our intervention and who needs us to step back and just watch.
Which leaves us with a final provocative thought for our listeners to consider as they go about their day.
We discussed that widening gap between incidence and mortality. If we are curing people who never would have died from their disease people with these small incidental findings, does the definition of cancer in the thyroid need to be reconsidered for these small indolent nodules?
Are we treating the patient or are we treating the ultrasound image?
That is the question. As imaging technology gets even better, we will find more and more of these tiny foci. The challenge for the next generation of hospitalists and endocrinologists will be having the courage to not treat and the wisdom to know when that is the safest and kindest choice for the patient.
Thank you for joining us on this deep dive into thyroid carcinoma.
It has been a pleasure.
Until next time.